Thank you, Paul. And we'll go right on to introduce our next speaker. Thank you, Charlie, for that wonderful presentation. I think it will stimulate a lot of discussion for our panel. So our next speaker is Dr. Stephen Johnson, who's a professor of medicine in the Division of Infectious Diseases at University of Colorado at Denver. He's the Associate Division Head for Clinical Affairs in the Division of Infectious Disease. He is the Director of the University of Colorado HIV/AIDS Clinical Program and the Medical Director of the Colorado AIDS Education and Training Center. Steve is well known for his contributions to our knowledge about primary care of HIV and new therapies for HIV for persons living with HIV infection. And he's going to talk to you today about primary care concerns for the aging person with HIV infection. Steve?
Thank you, Dr. Benson and Dr. Volberding for inviting me. Thank you for IAS-USA for putting this together. And I appreciate you all for attending. As Dr. mentioned, we're going to focus on primary care concerns for the aging population, a topic that gets more important each year as our ability to treat HIV has progressively improved. I do have one disclosure that I have listed here. The objectives are really threefold. First of all, I'd like to review for you the common comorbidities in older people with HIV. If you are in practice and doing a lot of care, I think this is a very familiar subject for you, and also recognizing what leads to death. I then want to turn and talk about age-related recommendations from mostly the U.S. Preventive Service Task Force, although I will mention the IDSA primary care guidelines, focusing on some of the recommendations that have specific age ranges. And then I'll end by talking about immunizations in older people with HIV. So let's start by understanding the causes of morbidity and mortality in older people with HIV. And of course, HIV as a cause of death has declined dramatically over time. In the current situation, the majority of deaths among people with HIV who are in care are related to other conditions. For those individuals that have a death due to HIV, as is illustrated on this slide from the CDC, what has happened over time is that people have continued to live longer, and that if HIV is a cause of death, it occurs at an older age. You can see at the right side of this graph that at the time of death due to an HIV-related cause, half of the individuals were 55 or older. But most of the causes of death are not HIV-related. So here's another CDC publication looking at the death rate over time, rates per 1,000 persons with diagnosed HIV infection. So if you want a percent, you could just take the y-axis and divide by 10. The solid line indicates total deaths, and you can see that has continued to decline. The era of highly active antiretroviral therapy began in the mid-1990s, but we continue to see improvements overall on HIV outcome, and I think that probably reflects improvements in care, improvement in the quality of our HIV medications, and perhaps more of a focus on other aspects of care like primary care. If you take these deaths and look at HIV-related deaths, that's the dotted line there. And you can see that has continued to decline in the current era. But if you look at the dashed line, which represents non-HIV-related deaths, that looks more like a plateau. And of course, this is a partial list of the comorbidities that we commonly see in people with HIV, mental illness, substance use, often polysubstance use, complications of human papillomavirus infection, including genital cancers, head and neck cancers, complications of viral hepatitis, including end-stage liver disease and hepatocellular carcinoma, sexually transmitted infections. Certainly globally, tuberculosis is one of the most important comorbidities. There are a series of metabolic conditions, some of which are quite a bit more frequent in people with HIV, and then non-AIDS cancers. non-AIDS cancers may turn out a bit to be a misnomer, as some of these cancers may actually be related to immunodeficiency. This is a study from Kaiser Permanente looking at life expectancy at individuals from age 21. And you can see the triangles represent people with HIV infection, and the dots represent people without HIV infection. So if you look at total life expectancy, you can see that this gap has progressively closed. There may be still a 5 or 10 year gap as a group for people with HIV versus without HIV, but it continues to narrow over time. However, as illustrated on the bottom of the slide, if you look at comorbidity-free years, then you see a significant difference that has not really changed. And in the box on the right, you can see some of the definitions of comorbidities that were included in this study. And if you look specifically at the events per 100 person years of any comorbidity and specific comorbidities, you can see a difference in overall mortality, but then also kind of striking here, chronic liver disease, chronic kidney disease, lung disease, diabetes, and cancers. So I think it underscores the importance of us focusing on primary care screenings. Some of us, come out of infectious disease programs and infectious disease clinics, and I think it's especially incumbent on us to either develop better primary care skills or to partner with individuals that are involved in primary care. In Colorado, I'm involved with several outreach clinics that involve collaboration with family practitioners and a general internist, and it's a pretty attractive model. I learn a lot from them about primary care, and again, as time has gone by, comprehensive primary care is a key to outcome for people with HIV. So there are some resources for primary care screenings of people with HIV. I'm going to focus on two here. One is the U.S. Preventive Services Task Force, of course, which has 53 different recommendations that have either a grade A or grade B recommendation. And again, I'm going to focus on the subset that have specific age-related guidance. But I do want to also mention the primary care guidelines for people with HIV. These were actually just updated in 2020. So it's a very contemporary and comprehensive resource for you to use for guidance for managing patients. So the U.S. Preventive Service Task Force provides different grades for its recommendations. And in general, grade A and B recommendations should be offered. The service should be provided. And the other thing related to that is that commercial payers and other sources of coverage tend to cover these screenings. As I mentioned, 53 of these recommendations currently have A or B ratings. And so I've just listed them in a couple tables here. AAA screening, ultrasound one time in men age 65 to 75, whoever smoked. I know we were talking about the electronic medical record in the previous discussion. Most electronic medical records, including ours, are actually pretty good at prompting us with a health maintenance module so that we can kind of keep some of these recommendations in hand. Diabetes mellitus screening, of course. Aspirin used to prevent cardiovascular disease and colorectal cancer, recommended in adults age 50 to 59 who have a 10% or greater risk of cardiovascular disease, are not at increased risk of bleeding, and have a life expectancy of at least 10 years. Breast cancer screening has an age range of 50 to 74 years, biennial screening in women. And then cervical cancer screening has an age range at least up to age 65 years. I wanted to emphasize this screening for breast and cervical cancer in women with HIV, and for this I'll refer to the IAS-USA primary care guidelines, which again were very recently updated. The guidelines are actually quite similar. Breast cancer, age 50 to 75 years, performed at least every 2 years. And then cervical cancer for those above 30 years, there's an option of Pap smear only versus Pap with HPV testing. And in general, again, continue screening past 65 years. One of the interesting articles that I recently read was the growing population of adults who will be over 100 years old in the United States. And that makes me think that some of these age-related recommendations may need to be adjusted over time. And also, I appreciate Dr. Flexner's point that some people are physiologically older than other people or younger than people, despite a similar age. One other table, so other screenings, colorectal screening, we've traditionally done this from individuals aged 50 to 75 years, but earlier this year there was an update, a B recommendation for adults aged 45 to 49 years. There's a specific recommendation regarding falls prevention, hepatitis C screening, CT lung cancer screening, which also was recently adjusted to just 20-pack year history, and then osteoporosis screening. There are some differences in guidelines, of course. The USPSTF really focuses on postmenopausal women less than 65 years at increased risk, as well as all women 65 years and older, whereas our IDSA guidelines recommend screening in all postmenopausal women and men who are age 50 years or greater. I wanted to mention a little bit about cause of death because I think it helps to inform the importance of the screenings that we're doing. This is from the DAD study. The DAD, of course, is that very large cohort where we've learned a lot about a lot of things, the incidence of comorbidities, side effects of antiretroviral therapies. But they've also had a very systematic approach to categorizing causes of death in people with HIV. And this is data from a publication in 2014. The columns on the left is the time period of 1999 to 2000. The columns on the right are 2009 to 2011. You can see some changes have occurred over time, and of course, if we had an even more contemporary analysis, some of these trends may have changed further. But you'll see a decline in deaths due to AIDS, that's in the light blue, and you'll see a jump in the percentage of deaths due to non-AIDS cancers. We looked at this at our own program at the University of Colorado, where we looked at 100 consecutive deaths over a 6-year period. We have a relatively large HIV program, and could categorize 32 of those deaths as cancer deaths. Now, a couple of these, would be AIDS defining, certainly lymphoma and cervical cancer. But you can see the prevalence of some of the other conditions, including lung cancer. And in the key on the right, I've put some of the cofactors that we think are important: HPV infection, viral hepatitis, tobacco use being still more prevalent as a whole in people with HIV compared to the general population. This is another cohort that looked at cancer as a cause of death in people with AIDS in the United States. Very big cohort, 83,000 people. Non-Hodgkin's lymphoma was the most common cause of cancer death, but lung cancer was the most common non-AIDS cancer. And so I think it's appropriate to emphasize the CT lung cancer screening. Again, JAMA earlier this year, the 2021 update of their 2013 recommendation, and applies now to people aged 50 to 80 years who have a 20-pack year history of smoking and either currently smoke or have quit within the past 15 years. Annual screening with low-dose chest CT, and then the caveat that screening should be discontinued once the person has not smoked for 15 years or develop a health problem that substantially affects life expectancy. Now, this is another study that I like to use to point out the prevalence of non-AIDS cancers. This is a comparison of cohorts. The numerator is actually 2 different HIV cohorts, the HIV outpatient study, or HOPS, and then the Adult Spectrum of Disease project. And then the comparator arm is actually a general cancer cohort in the United States called SEER. And by comparing these cohorts, then generating these standardized rate ratios. So the way you read this table is that people with HIV have a risk of anal cancer that's 43 times that of the general population. And of course, a number of other cancers that are listed here are at statistically higher levels. And I think when you look at the list, you can think of some of the cofactors we've already talked about in terms of tobacco use and HPV infection, for example, viral hepatitis. One of the interesting things is some of the studies that have looked at lung cancer, even when you control for tobacco use, there has been an association with a low CD4 count and or a low CD4 nadir. So although much of this may be due to these comorbidities, these other infections or habits such as tobacco use, it's also possible that there's a component of HIV itself, that a period of immunodeficiency reduces immune surveillance and increases the risk of cancer. So I thought I'd also then emphasize the colorectal cancer screening. This was a 2021 update of the 2016 recommendation. Recommending colorectal screening in all adults 50 to 75 as an A recommendation, but now a younger group, 45 to 49 years. And I'd be interested from the group today whether any of you have operationalized this lower age range for screening. And I included that screening may be offered to selective individuals age 76 or higher based on overall health prior screening and preferences. I think this is important to mention that despite the presence of these guidelines, that there can be room for clinical judgment, and provided you can get certain screening tests covered, it may make sense to screen beyond the ages recommended in certain settings. And I just list some of the screening methods, which can include either stool-based tests or visualization methods. So, as it illustrates, I think an important strategy in the clinic now is to have a specific approach to cancer screening. And I've listed some of the common cancers and some of the important interventions here. As you can see under anal cancer, the use of anal cytology is still a bit of a question mark. We and a number of other centers are part of the National Anchor Study, which is really going to help to determine whether treating high-grade dysplasia can prevent cancer. We'll look forward to the results of that story. And again, I think many of the other items on this slide are self-explanatory. So in the remaining few minutes, I want to turn to immunizations in older adults living with HIV. And I'll start with a slide that I put together to kind of, look like the immunization schedule that the ACIP publishes, but this is specifically for people with HIV. And it may reflect a little bit of my bias. So, for example, in individuals over age 65, I actually do favor the high-dose influenza vaccine. You could also argue that the new adjuvanted influenza vaccine, which is more immunogenic in older individuals, might be preferred. The ACIP has generally not expressed a preference on flu vaccines and says just get a flu vaccine. The other thing I'll mention here is that, at least in our practice, and I presume yours, that the recombinant zoster vaccine has really essentially replaced the live zoster vaccine. And then down at the bottom, of course, we now have the COVID-19 vaccine. Again, CDC states no preference. Maybe the panel will have interesting thoughts about this. Our group, I think, has favored the two-dose mRNA vaccines, either Pfizer or Moderna, but frankly, we need additional data to kind of guide those types of specific recommendations. I mentioned the high-dose influenza vaccine. I have a series of references here. We know it's more immunogenic in individuals 65 or older. We know it's more immunogenic in people with HIV. One of our local practices in Colorado here gives the high-dose influenza vaccine to everybody with HIV, regardless of age. We also know that, at least in one study, it's been shown to provide better protection for laboratory-confirmed influenza. And also in one flu season, was demonstrated to have a mortality benefit. Now, I wanted to mention that the opportunistic infection guidelines were actually just updated earlier this year, and there was a significant update of the immunization section. So I'd encourage you to look at the immunization section because there's some new resources there, including some differences between what the OI panel recommends versus what the ACIP recommends. And this is just, I've extracted a table here so that you can kind of see how it's laid out in terms of the different vaccines and where it varies by age and of course also by CD4 count. So just to summarize immunizations in older adults, consider the high-dose influenza vaccine. Certainly recombinant zoster vaccine is preferred over the live zoster vaccine. Of course, age 65 is an indicator for a booster of the polysaccharide vaccine, provided at least 5 years have elapsed since the last dose. And then you continue to boost the tetanus and the meningococcal vaccines. The recommendations are for the meningococcal vaccine I find kind of interesting. It's really a pretty uncommon disease, more common in people with HIV, but still very uncommon. I want to end by just mentioning a couple things about COVID-19 vaccines and HIV. Some of the large cohort studies have reported a higher risk of mortality in people who develop COVID-19, and the CDC has now recognized HIV as one of the medical conditions that increases risk. And of course, people with HIV separately often have other comorbidities associated with COVID-19. Currently, the ACIP does not express a preference regarding which vaccine to use. So these are some of the factors that I think you associate with severe disease with COVID-19, and you can see that they're common in people with HIV. One of the things that we're most proud about is that over 50% of people with HIV in the United States are over 50 or close to that. Obesity is common in HIV, and now we're evaluating weight gain with ART, cardiovascular disease, lung disease, increased tobacco use, and so on. And the other thing is that studies of COVID-19 deaths have shown a higher rate among men, and we don't know how much of that is biologic versus behavioral, but of course, in the United States, the HIV epidemic is proportionally higher among men. So I thought I'd just leave you with a few talking points for people with HIV, just in case you have some vaccine hesitant individuals that you're dealing with. I think it's important for people to know that people with HIV were included on all of these trials, but we are actually waiting on more specific information about response to these vaccines. None of the COVID-19 vaccines, of course, are live vaccines. The other point I like to make is people with HIV on ART with a normal CD4 count, we expect them to respond well to licensed vaccines. So we might expect the same with COVID-19 vaccines. And people with HIV of advanced disease may have a reduced response to vaccines, but they're also at greater risk for severe COVID-19. So what have we talked about in this talk? Life expectancy continues to improve for people with HIV. So focusing on primary care is critical. Comorbidities continue to play a large role in morbidity and mortality. And many of the U.S. PSTF recommendations are particularly important for older people with HIV. I've highlighted that there are updated guidelines for lung cancer and colorectal cancer screening. And of course, a number of immunizations are important in older people, and the role of COVID-19 vaccination continues to evolve. So at that point, I will stop, and I can go ahead and unshare my screen, and be happy to answer questions or equally hear comments from the rest of you.
Oh, thank you very much, Dr. Johnson. That was a spectacular talk and very informative. So I'll start. This is a comment, but I'm going to turn it into a question in a moment. But one of the comments in our Q&A is that many practitioners would continue breast cancer screening for women older than 74 who have at least a 10-year life expectancy. And I would think that for people with HIV who are well controlled on antiretroviral therapy, that would apply to women older than 74 with HIV as well. You have any comment related to that?
Yeah, I would, I'm reporting these kind of guidelines, but, sometimes our clinical practice varies, and we've certainly continued screening mammogram in women over age 75. So again, I think there's room for clinical judgment. There's room for kind of a shared discussion with the patient, but we have not actually, in fact, for a number of these different recommendations, as long as we can get them improved, we've tended to not necessarily use the upper bound of the age as a firm recommendation to stop. So I certainly support the comment, to continue screening. It's worthwhile having a discussion with the patient about the benefits of screening, and even healthy people may change their minds over time. So that's a good point.
And I guess along the same lines, the cervical cancer screening for women over the age of 65 is no longer recommended for people without HIV infection. Mm-hmm. Would you continue to do cervical cancer screening for women with HIV infection over the age of 65?
Yes, I would. And actually, there's a discussion, in the IDSA guidelines about, and they kind of use the term past 65 years, which is a little bit, allows you a little bit of wiggle room. But again, it's, and obviously people that have, cervical dysplasia and so on, it's, you wouldn't want to arbitrarily stop at some period of time. And again, we're that life expectancy line that continues to kind of narrow and so on. I think many of our HIV positive patients will, that are physiologically doing really well at age 75 may live another 10 or 20 years. So again, I think that's a related good point, is that we have to think carefully about stopping just because of an age range. Now, one of the issues you run into, is could you get pushback from payers and things like that if you're trying to do things that are outside of the guidelines? But I haven't really seen that we've had much difficulty with that. Sometimes we change our referral a little subtly, to kind of reflect our concern about something, so it sounds a little bit less like screening and more like we're doing it for clinical indications.
And another question that comes from our audience: are there any current data regarding KS incidence in older age groups with people living with HIV?
Well, maybe others on the panel can answer that. I'm not aware. We've anecdotally still see an occasional case of Kaposi sarcoma. Certainly the overall incidence in the U.S. seems to be quite a bit lower, but I can't really cite specific data.
And how about commenting on doing anal pap smears in patients at risk for HPV infection? I think you covered this a little bit in your talk, but maybe expand a little.
Yeah, and I would encourage you actually to look at the discussion of this in the new IDSA guidelines, because it's a little bit more in favor of doing anal cytologic screening. I think, as I mentioned with the ANCHOR study, we actually don't know at this point that aggressive treatment of high-grade dysplasia versus a very, active monitoring program actually reduces, the risk of anal cancer compared to, careful digital rectal exams and other types of screening. I think hopefully that the Anchor trial will help to definitively answer this. We've really offered it as a standard of care in our clinic for quite some time. But when individuals are in certain settings, perhaps rural clinics without, access to groups that do high resolution anoscopy, it's certainly not wrong not to do it. And part of the guidelines are, if you are going to do it, then you actually need a program in place to kind of react to the findings. And so if you're finding high-grade dysplasia, ideally you would have a referral to undergo high-resolution anoscopy. I know that our program here at the University of Colorado and Denver Health, we actually have individuals coming from all over Colorado, coming to our anal rectal disease clinic to kind of get these screenings. But again, if you're not in a position that you can do it, I don't think it's wrong to not do it. But I do think it's then very important for digital rectal exams.
Great. Well, I think that's all the time we have for questions. So any additional ones we'll answer in the panel discussion. And thank you very much for really a wonderful talk, Steve. I'm going to turn it back over to Paul to introduce our last speaker of the day.